You've trusted gadolinium contrast as routine and safe. So have your colleagues. So did the FDA until 2015. That's when they confirmed gadolinium deposits in human brains, even in patients with healthy kidneys. But one question remained unanswered. Does retention cause harm? We surveyed 316 patients to find out. What we found changes the risk-benefit calculation for every contrast MRI. For decades, patients with normal kidney function have been reporting symptoms after contrast MRIs. For decades, they've been told, "It's not the gadolinium, your kidneys are fine." But gadolinium doesn't need kidney failure to deposit in tissues. The FDA confirmed that in 2015. So we asked, if it deposits, does it harm? 316 patients answered. The consistency of their symptoms is impossible to ignore. Gadolinium transformed diagnostic imaging, clearer pictures, better lesion detection, confident diagnoses. It seemed like a miracle, a metal that would pass through the body harmlessly, leaving only information behind. But gadolinium had other plans. It didn't just pass through, it stayed, and we're only now learning what that means for patients. Gadolinium is toxic, so we chelate it, wrapping it in a molecular cage to keep it bound until elimination. But the cage breaks, and when it does, free gadolinium deposits in tissues, brain, visible on MRI scans, bone, detected for 14 years after a single dose, skin, confirmed by biopsy, even in patients with normal kidneys. Every patient retains some gadolinium. The amounts aren't trace, they're measurable, persistent, and cumulative. The question medicine hasn't answered, is retained gadolinium inert or active? The FDA itself confirmed in 2015 what patients had been reporting: gadolinium deposits in brain, bone, and skin, even in patients with perfect kidney function. If the premise changed in 2015, shouldn't our clinical response have changed too? 316 patients, normal kidney function, 60 symptoms tracked systematically, plus 8 biopsy-confirmed NSF cases for comparison. Because we knew you'd want objective validation. This isn't a collection of internet complaints. This is the largest patient-centered dataset on post-GBCA symptoms ever compiled, following the same rigorous methodology you'd expect in your own research. What we found surprised even us. The patterns were so consistent, so specific, that they couldn't be explained by coincidence, confirmation bias, or functional disorders. Let's start with the finding that made us reconsider everything we thought we knew about NSF. 19 of the top 28 NSF symptoms appeared in our normal kidney patients, not similar, identical, including 11 neurological symptoms. NSF is biopsy-confirmed, FDA-recognized gadolinium toxicity. If the symptom profile matches but the kidneys don't, what does that tell us about the real mechanism? Industry messaging says macrocyclics are safer. Our data says otherwise. In 75 unconfounded cases, with single-agent confirmed retention, symptom profiles were statistically indistinguishable. The question isn't linear versus macrocyclic. It's whether any retained gadolinium is truly inert, or whether we've been measuring the wrong endpoints. Before we go further, let's be clear about what we're not saying. We're not saying ban gadolinium contrast. We're not saying every symptom is caused by gadolinium. We're not saying you're a bad doctor if you've ordered contrast. We are saying, listen to patients. Investigate the patterns. Demand better research. We are saying, informed consent should include long-term retention and potential symptoms. We are saying, the absence of evidence isn't evidence of absence. This is about improving safety, not assigning blame. 11 of the top 19 symptoms were neurological: burning pain, tingling, brain fog, muscle fasciculations. This isn't random. Gadolinium is a known calcium channel blocker, and calcium channels control every neuronal process. You've seen these symptoms before. You've probably diagnosed them as fibromyalgia, functional disorder, or medically unexplained. What if they weren't unexplained at all? The data tells one story. The lives behind the data tell another. These aren't worried well patients catastrophizing normal symptoms. These are people who lost careers, independence, and in some cases, the will to live. If even 10% of what they report is real, and our data suggests it's far more, we have a moral obligation to listen. 38% develop new diagnoses post-contrast: fibromyalgia, small fiber neuropathy, MCAS, Hashimoto's. These aren't separate diseases. They're the labels we give when we can't find the cause. What if the cause was sitting in their bones, brain, and skin all along, and we just weren't looking for it? 43% changed or lost employment. 41% reported cognitive impairment affecting work performance. 20% became disabled. Imagine one of your colleagues, sharp, capable, suddenly unable to focus, remember protocols, or stand through a shift. Then imagine being told it's just anxiety. That's what we're asking you to see. 24% of patients with confirmed retention reported suicidal ideation. We can't prove gadolinium caused it, but we know chronic pain, disability, and medical dismissal are suicide risk factors. When we tell suffering patients it's all in your head, we may be contributing to the very outcome we fear most. This is the safety signal that should keep us up at night. 13% developed new autoimmune diagnoses, plus MCAS, immunoglobulin deficiency, and chronic inflammation. Gadolinium is a known immune activator. It triggers mast cells, excites pro-inflammatory cytokines, and disrupts mitochondrial function. This isn't speculation. It's published, peer-reviewed science. We're just connecting it to patient outcomes for the first time. Our survey captured 316 patients. But who didn't we capture? The patients who haven't yet connected the dots. Those too cognitively impaired to find us online. Patients too disabled to complete a 45-minute survey. Patients who died from suicide, from complications, from causes never connected to that MRI years ago. Every survey has survivorship bias. Ours probably underestimates severity. If this is what the survivors look like, what happened to those who didn't survive? If you're skeptical, good. You should be. Patient reports alone aren't enough. So let's look at the mechanistic data, the biochemistry that explains why these symptoms aren't just possible, but predictable. Gadolinium's ionic radius mimics calcium, but binds 1,000 times more tightly. It blocks calcium channels, disrupts mitochondria, triggers inflammation, all documented in vitro and in vivo. One metal, one mechanism, dozens of symptoms, because calcium channels control everything from nerve firing to immune response. It's not a mystery, it's toxicology. Gadolinium doesn't just deposit, it forms nanoparticles. These particles cause mitochondrial swelling, cellular lysis, and pathological endosomal structures. Not in theory, in human tissue samples. They persist for years, decades in some cases, and kidneys can't clear them because they're locked inside cells. This is chronic metallosis, and it's happening in your patients right now. NSF was identified by dermatologists, so we focused on skin. But gadolinium deposits everywhere. What if NSF isn't the only severe form, just the most visible? Severity isn't fibrosis versus no fibrosis. It's mild. Symptoms don't stop you working. Moderate. Symptoms force career changes, disability claims. Severe. Bedbound, cognitively impaired, suicidal, or dead. Same metal, different vulnerabilities, different manifestations. And we're missing the sickest patients because they're too ill to find us, or they didn't survive long enough to connect the dots. NSF was identified by dermatologists looking at skin. But gadolinium doesn't just deposit in skin. It deposits in brain, bone, liver, throughout the nervous system. Severity isn't just fibrosis and contractures. It's also the software engineer who can no longer code, the nurse who needs a wheelchair. Different manifestations, same devastating impact. We need to stop measuring severity by what we can see and start measuring it by what patients lose. We're not asking you to abandon contrast imaging. We're asking you to see what's been invisible. The data is here. The mechanisms are published. The patients are in your waiting rooms. What happens next depends on whether we choose to look or look away. Can we prove gadolinium caused every symptom in every patient? No. Can we prove it caused none of them? Also no. But when 316 patients with normal kidneys report the same symptom clusters as biopsy-confirmed NSF patients, and those symptoms align with gadolinium's known mechanisms of toxicity, the burden of proof shifts. It's no longer on patients to prove they're harmed. It's on the medical community to prove they're not. And until we have that proof, we owe them the benefit of the doubt. Our survey shows a strong association between gadolinium retention and multi-system symptoms. Association isn't causation, we know that, but it's hypothesis generating. And the Bradford Hill Criteria are stacking up. We're not claiming proof. We're claiming the evidence warrants taking patients seriously and investigating further. Because the first step in preventing harm is admitting it's possible. Most post-contrast symptoms never get reported. Why? Because they happen after discharge. Because they're non-specific. Because we don't connect them to an injection from weeks ago. But every unreported case is a missed safety signal. Every dismissal is lost data. Report to FDA EMA, even if you're not sure, especially if you're not sure. That's how patterns become visible. We're told gadolinium contrast saves countless lives. But has anyone ever counted? Does it extend life, improve quality of life, reduce disability, or just create prettier images? How many patients are harmed for every patient helped? 1 in 100? 1 in 10? We have no idea. How do we treat gadolinium toxicity? We don't even have guidelines for NSF. Studies on these outcomes don't exist. We have 30+ years of gadolinium use and zero patient-centered outcomes research. We're using a metal that deposits in human brains without knowing if the benefits outweigh the harms. That's not evidence-based medicine. That's faith-based medicine. Let's get the evidence. Why do we order contrast? Often, it's FOMO, fear of missing something, fear of being wrong, fear of a lawsuit. But what if the something we're missing is the harm we're causing? Contrast should be a clinical decision, not a default. Ask, will this change management? Or just confirm what we already know? Can I get the answer another way? Non-contrast MRI, ultrasound, CT? Does the patient understand the risks? Not just allergy, but long-term retention and potential symptoms. Defensive medicine protects doctors. Evidence-based medicine protects patients. Which are you practicing? To the FDA, EMA, and regulatory bodies worldwide, reconvene your advisory committees. Update the 2017 guidance with 2025 data. Not necessarily to ban contrast, but to ensure informed consent reflects what we now know, to require reporting, to fund the research that answers the questions patients are asking. You changed course on NSF when the data demanded it. The data is demanding it again. Every doctor enters medicine to heal, but what if the tools we trusted were causing the suffering we couldn't explain? You didn't know. None of us did. But now we do. The question isn't whether we were wrong, it's whether we're willing to be right, starting today.